So this is the second presentation that Professor Middleton was going to give today, so I'll try and do some justice and hopefully convey the necessary parts. I think this part complements the last talk quite well, whereas the last talk was focusing on ocular and rarer types of melanomas. This is talking about the genetics and the mutations that we commonly see within skin melanomas. So what we know, although the so-called mutational load, or the number of mutations, are higher in the rarer types of melanomas, there still are a number of mutations that are evident in skin melanoma. This chart basically shows that there are many mutations that have been identified amongst patients with skin melanomas. Now, fortunately, the most common two, BRAF and NRAS, are things that we can potentially do something about. The BRAF mutation is present in about 50% of cases, and it is so-called actionable because we have a drug that can target it, so with some therapeutic benefit. This is important because although the focus of my previous talk and also a lot of the work today is on immunotherapy, immunotherapy does not benefit everybody, and there is still work to be done. So what do we do for these other patients? Well, we can look at targeting these actionable mutations. So to talk about some of the mutations, as I'm sure some of you will be aware, if your melanoma has a BRAF mutation, we currently target these with two drugs. A BRAF inhibitor, there are two types, vemurafenib and dabrafenib, which are in regular use, and MEK inhibitor, we commonly use a drug called trametinib. For patients with an NRAS mutation, slightly less common than BRAF mutations, but still not that rare, there's a suggestion that a MEK inhibitor may help, and I'll explain this in some future slides. If you don't have a BRAF mutation or an NRAS mutation, well, what are the options? And again, I'll show you some data that suggests we may have options for this subgroup of patients in the future. I'm not going to explain this in detail, but the point of these slides is really to show that if you have a BRAF mutation, we give you two drugs. At the moment in Oxford, dabrafenib and trametinib. These drugs work spectacularly well in the vast majority of patients in a very short period of time. But of course, the story is too good to be true. And unfortunately, resistance to the drug often develops, and the drugs stop working just under 12 months, in about 10 months. And what we commonly see is the disease bounding back with a vengeance. And that's where we need to move to other treatments. So understanding the mechanisms of resistance to BRAF inhibitor treatment is very important. And evidence suggests that, amongst other reasons, activations within the NRAS pathway may be a cause of this. I think this slide is quite interesting. So another concept is the concept of intermittent dosing with these drugs to try and reduce resistance. So at present, if you have a BRAF mutation, you will get dabrafenib and trametinib, which you will take continuously. There are no breaks. Now, the problem that could eventuate from this is that if you keep exposing the melanoma to these drugs, you give the melanoma a chance to develop resistance. I mean, the melanoma, like everything else, is trying to survive and do what it can do to get around the treatments that we're throwing at it. So, in theory, the more exposure you give a melanoma to a drug, there's a chance that you increase the chances of resistance. And there is some work that has shown that if you periodically expose a tumour to a drug, then stop, then do it again, you can increase the period of clinical benefit. And that's what is shown here. Now, of course, this needs to be shown clinically, and there is the Interim trial is mentioned here is answering that particular question. So patients in this trial will either take dabrafenib and trametinib continually, as per the standard of care, or intermittently, and we'll see what happens. On this note, I will mention a common question that I'm asked in clinic is when patients run out of their tablets, or they're admitted to hospital, they have a problem with toxicity, and we ask them to stop taking their tablet. They're very concerned that their melanoma will recur in a very short period of time. And although this is yet to be proven or shown, just to lower your concerns, there at least is some belief that this intermittent exposure may potentially be a good thing. So if you do take a treatment break or your tablets do run out, of course that's not ideal because the current standard of care is continual treatment. It's not necessarily as big a problem as you may think. So to go back to this axis, now Dr. Stephen very well elegantly showed this MAP kinase pathways on his previous presentation, some with multiple steps, and it's better illustrated here. So this MAP kinase pathway is essentially a collection of switches, or switches starting with NRAS at the top there and ending down to ERK. Now, if you have a BRAF mutation, what happens is the BRAF protein there, which is in green, is permanently turned on, and therefore activates the switch downstairs stream MEK, which then activates the downstream target of that ERK. Now, beyond that, ERK is responsible for activating many proteins and many factors that promote melanoma aggressiveness. Now, luckily, when you target BRAF with a drug, you stop this, which in part explains why BRAF inhibitors are so effective. Now, mutations in RAS, common in, I think, about 15% of patients with melanoma, are still problematic. And current work is looking to mitigate the effects of its activation by targeting the downstream protein MEK, and there are a number of drugs currently in existence to do that. So the NEMO trial looked at patients with an NRAS mutation, the most common mutation being the Q61, randomising them to either chemotherapy, which is a very dated treatment, versus binimetinib, which is a MEK inhibitor. And what it showed is that there was increased activity or a benefit in terms of progression-free survival in those patients who were treated with the MEK inhibitor. Now, you have to appreciate that dacarbazine is essentially redundant. Today's a very dated chemotherapy drug, and with immunotherapy and everything else, I doubt it has a role. But still, this does show that there is a signal of benefit when you give a MEK inhibitor in this context that can certainly be taken forward. And unfortunately, there was no benefit in overall survival, but still there's a promising signal that it could go somewhere. A trial that I've been involved with in the past, and at Oxford and a number of centres here, I've seen a number of patients here today that have been involved in this trial as well, is the PACMEL clinical trial. So again, about half of all patients have a mutation within BRAF. So these patients at the moment have treatment options consisting of a BRAF/MEK inhibitor or immunotherapy. So basically, 3 options, given that there are 2 immunotherapies. If you don't have a BRAF mutation, you only have immunotherapy as your options. This is not including chemotherapy, but you have relatively fewer options. So patients without a BRAF mutation are essentially an area where we need to work on. And the PACMEL trial will ask the question, if we add a number of other drugs to chemotherapy, can we improve outcomes for patients without a BRAF mutation? So in this study, all patients received a drug called paclitaxel, which is a chemotherapy drug, and they either received nothing else, trametinib, which is a MEK inhibitor, combined with paclitaxel, or a drug that affects blood vessel growth called pazopanib. And what this showed was that patients who had the MEK inhibitor trametinib alongside paclitaxel had a better progression-free survival. In other words, that combination slowed the melanoma down better than paclitaxel alone. And it also had a response rate of about 42%, which I think is impressive. If you've got a large volume melanoma that's painful or causing a variety of symptoms, knowing that there's a potential therapeutic option that can cause response rates of this magnitude is impressive, and that will hopefully be taken forward. Inhibiting the NRAS-driven pathway via more than one mechanism is another strategy that is currently under consideration. So not just using a drug to inhibit MEK, but also another downstream target. And a clinical trial addressing this has been performed. This is a waterfall plot that Sarah gave an example of earlier. In this, every line is a patient. Those bars going up represent patients whose tumours are growing. Those bars going down represent those patients who have experienced some form of tumour regression. And as you can see there are a lot of patients who are experiencing at least some degree of tumour shrinkage on this combination. So again, this is a potentially exciting step forward for patients with NRAS mutant melanoma. So the slides here are very brief, but essentially, despite all the excitement and progress associated with immunotherapy, the mutations that melanoma has are very, very important. We already know that BRAF mutations untreated have a worse natural history compared to other types. And given the high rate of, given that a lot of patients do have NRAS mutations, we also need to look for treatment strategies to benefit this group as well. So that's where we are and moving forward. Thank you.